Good evening and welcome to the webinar Re-Engineering Primary Healthcare Centres in Kerala, organized by the Centre for Public Policy Research, CPPR, Kochi. I'm Nathishia Chandy, a Youth Leadership Fellow at the Centre for Public Policy Research, and I will be your moderator for the day. In today's discussion, we will delve into three directions of inquiry. The first is the importance and the characteristics of an ideal primary healthcare system. The second, the successes and the challenges faced and the pitfalls of the family healthcare centers instituted under the Ayushman Bharat mission and the Ardhra mission in Kerala. Finally, the improvements sought to be made in the primary healthcare system in Kerala. We will also delve into whether alternative approaches need to be explored. Before proceeding further, it is my honor to introduce the speaker for the day. We have with us Dr. S.S. Lal. Dr. Lal is an internationally acclaimed public health expert with over 25 years of experience working across the globe in leadership roles at the World Health Organization, the Global Health Fund, NGOs, private sector, government, and academic spheres. He is the founder, vice president, professor, and head of public health at the Global Institute of Public Health Trivandrum, and the founder president of the Global Foundation for Health and Hygiene USA. He also serves in advisory capacities for international organizations. He has held positions like the Senior Public Health Advisor to the UNEP, Public Health Consultant to the World Bank and the Global Fund, and in his stint with the World Health Organization, he oversaw program implementation in 25 countries across Asia, Africa, and Europe. He has been a pioneer in developing and scaling up innovative public health intervention projects at the local, national, and global levels that has influenced policy changes in disease control. Welcome, sir. It is
Thank
a
you.
pleasure to have you here with us today on this discussion. Before we begin, to give a little context to the discussion we're about to have here today, in February 2018, the Government of India announced that 150,000 health and wellness centers would be set up all over the country by converting existing sub health centers and primary health centers. This was declared as one of the two components of the Ayushman Bharat mission. In Kerala, these conversions were conceived in 2017 under the Ardhra mission, wherein the primary health centers in the state were to be converted in three phases into family health centers, the state's equivalent of the health and wellness centers. The re engineered version of primary health centers were designed to deliver continuous, comprehensive primary health care. That is, care that is not merely curative but spans preventive, promotive, rehabilitative, and palliative care, is universally accessible, equitable, affordable, quality linked, accountable, and responsive to the needs of the people. The conversion sought to achieve three major objectives: the decongestion of the secondary and tertiary health facilities, the reduction of high catastrophic out of pocket expenditure, expansion of population coverage, and the mitigation of risk factors for illness or disease within the community. So, I think a good place to start this discussion would be to chart out what an ideal primary healthcare center or a primary healthcare system looks like. What are its goals and why are such institutions even necessary?
No, this if we go back, it starts from the Almata Declaration, the primary healthcare concept, and so India, especially Kerala, was one of the places to seriously think about primary care and all. Basically, see, the health systems will not function itself, especially in making it accessible with providing equitable access to population. So you have to have intervention. So that's why that's one of the concepts for primary healthcare. You have to provide healthcare equally to people, equally accessible, especially taking care of marginalized population. So these kind and affordable. It should be affordable also. So that's why. So and we have been talking about universal healthcare. We earlier before 2000 we had this slogan of health for all by 2080. These kind of things were there. All these are aimed at providing quality, equitable, and affordable care to all people. so for that, it's not. There has to be, more effort, even beyond this kind of slogans. So you have to have practical steps. So you should have a organizational setup, institutions to provide this kind of care. So for that, you need primary health centers. So Kerala had the first primary health center in the whole country, even before independence. But after this board committee, NALMAT, all these things, primary healthcare mechanism system was improving in Kerala, all over in India also. This is basically to provide healthcare to all kinds of people, especially people in the villages, rural population, and across all kinds of population and across all kinds of age groups. And this is basically to integrate curative care and preventive care. And of course, palliative care and those kinds of things. So that's how. So wherever these kinds of things are met as per the policy guidelines or as decided by the governments, things will be better. So there is wide variation. If you look at the different states of India, or even if you compare India with other countries, there's wide variation. Everything depends on the political will of the governments, the resources available, the mechanisms, or how the health systems function, and health awareness of the people. So there are a lot of systems. There are a lot of factors that influence how this is being delivered.
So you spoke about how why these institutions are necessary. What do you think are some of the pitfalls of the primary healthcare systems in Kerala?
See, compared to other states, primary healthcare system in Kerala is much better. That doesn't mean that all primary health centers are meeting the objectives of primary care. So in terms of number, we have more than 900 primary health centers, roughly one primary health center per panchayat, that is there. And a large number of primary health centers, especially in the recent years, have been upgraded with additional facilities, manpower, all those things are there. But as a person who has worked in a PHC many years ago and who has been seeing primary health centers across the country, I can say that Kerala also has to improve a lot. There are multiple factors. Of course, different governments come into power and they influence policies. All democratic governments have contributed to primary healthcare system. But at the same time, there are some intrinsic characteristics of Kerala. So unless we address those characteristics or those problems, we will not be able to achieve what we desire. If I give specific examples, there are PHCs located in places which is not accessible to people, on the top of a mountain, whatever. So that's where government got the land donated by some landlord, and the PHC was set up. So PHC should be catering to the needs of the people. The sick people will not climb up a hill. So that this kind of things. The other thing is the timing of primary health sectors. Now this is being changed. So people go for, almost everyone works in Kerala adults. When he goes to the office or workplace, the PHC is not open. When he comes back, the PHC is closed. So this is why people seek care from the private sector. See, more than 60% of the people in Kerala, they seek care from the private health sector. And see, it's more than availability of resources or staff or timing. See, the friendly approach. The government has its own way of behavior, whoever rules the state or whatever. So government systems in most of the developing world, it has its own inertia, or it has its own pace. So when people come to such government facilities, many places they are not treated well. They are not. There is no friendly treatment. When you talk to people, or there are researches that show that, studies that show that even when public health care facilities available, very close to people's residence, still they prefer to go to a private sector. This is so different factors are there. So this is there, especially in Kerala. So people don't have a lot of time to spend in public hospitals. They need friendly care. They need the facility. They want to communicate, and the timing should also be convenient. So this often doesn't happen with the public sector hospitals. So more than number of facilities or the facilities within the public health sector care centers, it depends a lot on how it functions, how it is available, or how it is accessible, how friendly is this for the public. So that's one of the barriers. So we have enough numbers, and this conversion from PHCs to health and wellness centers, and this the other one, family health center. These things are happening. PHCs are being converted into family health centers, and sub-centers are being converted into health and wellness. And these things are happening slowly. The pace is also okay, but the change of names or the change of programs may not serve the purpose. That's what we have to look at. And when it comes to the private sector, I told you, more than 60% of the people seek care from the private sector, which is not a bad thing, provided this is affordable. So out-of-pocket spending is a big issue when people go to the private sector. And even in the government sector, people have to pay from their pocket due to different reasons for different expenses. Something like 7,500 rupees per capita. That's what I remember. Funding is there for even for public centers. And when it comes to the private, it is something like 30,000 rupees per capita. So these are issues, and especially in the times when the economy of the whole world is affected. Financial crisis is there from governments to individuals. This is something which we have to be worried about.
So you mentioned how PHCs are being converted into FHCs in Kerala and all through India into health and wellness centers. So under the Ayushman Bharat scheme, there is a requirement for expanded range of services and digitization of both health records and service delivery. And there's also the requirement of population empanelment. And there's also, like you said, emphasis placed on health promotion and awareness. And all of this is with the goal of universalization of healthcare in Kerala. According to the Controller and Auditor General report that was published in August 2023, only 131,000 Ayushman Bharat health and wellness centers that have been established in India are functional currently. And in Kerala, like you said, the conversions are still underway, but there's a good pace that's been maintained. The question is, sir, what have been some of the successes and the challenges in the implementation of the mandate of the Ayushman Bharat scheme in Kerala? And is universalization of healthcare, is that a feasible goal in Kerala?
The success is relative, especially in a country like India. And see, the utilization of PHCs, that also varies between different parts of the state. So especially in rural area, PHC people go to PHCs and they avail service, they seek service or care from PHCs. When it comes to urban areas are dominated by big private hospitals, and so that difference is there. There is success in kind of transitioning from these PHCs to FHC. Those kind of things are happening in Kerala also. But like I said, the change of name alone will not be enough. And of course, you have to recruit enough number of staff, because the number of staff have to be more. Different categories of staff have to be there. So that is taking time. recruitment is slow in Kerala and a lot of vacancies are unfilled, especially of other paramedical and field level workers. There are a lot of vacancies are there. These are some of the issues. And again, that is also linked to the financial state of the government. When the government doesn't when the government doesn't have enough money, there will be ban on direct or indirect restrictions on recruitment. All those things are there. So overall, the progress is good compared to other states, but that doesn't mean that other states are lagging behind. I have gone to some of the South Indian states, other South Indian states. They have some of them have very good progress. So, so it's a transition. It's a period of transition. So we'll have to wait for some time, and there should be societal and political pressure on the governments to make it faster. And as you know, the investment in health is generally less. It's not a priority area, even though it's a priority area for people. Often for governments, it's not a priority area. So budget allocations or the percentage of GDP spent on health, all these are very low even now in India as well as in our state. So these are some of the issues that we have to address. Plus, again, like I said, private sector is a reality. So it has to be considered as an opportunity. So private sector grows into the space created by public sector. When the public sector service is not available or is of poor quality, people go to private sector. That's a normal process that happens in communities. So often what happens is governments or government institutions compete with private sector, or private sector is considered as an enemy. That's a problem of the mindsets. This happens in many countries at national level also, even in Kerala. So there has to be more inclusive approach. When private sector is a reality and 70% of your population go to private sector, you have to make a private sector partner. This boss-servant relationship between the government and private will not work, at least in the health sector. And when you look at the realities, see, many private hospitals or private sector providers or their owners are more powerful than even some of the government counterparts. So this is a reality. So private sector has to be engaged like a partner, and there should be stewardship from the government. Government should not be policing the private sector, because private sector itself is not a single entity. It's very diverse, it's very disorganized. So there has to be regulation. So regulation should not be policing. Regulation should be aimed at getting or providing quality care from the private sector also. So that's not what happens in the field often. So that's how. So there are many areas like this which we have to address while we have this transition.
So you've spoken quite a bit about the reliance on the private sector. That you said that more than 70% of the people in Kerala prefer, and also in actuality do rely on the private sector for healthcare requirements. So, what do you think is the role of the private sector in disease prevention? They treatment, like, we understand that the private sector treatment is something that people opt for, but does the private sector also have a role to play in disease prevention?
Of course. So, but to what extent it happens is a different thing. So private sector, naturally, their orientation is towards curative services. So people don't think that all people will be aware of preventive aspects of health. Now, people go to doctor or a care provider when they fall sick. That's it. In cities or educated population, things will be slightly different. But generally, people go to a provider when they fall sick. That's why this shift from preventive care to curative care all happened, because people want their sickness to be taken care of or their illness to be cured as early as possible. That's why hospitals had to be more equipped. Private hospitals, a lot of private hospitals erupted because of this need. That's a reality. At the same time, private sector also has to look at the public health aspects. This is happening, but that like I said earlier, this has to be promoted by the public sector. There should be stewardship from the private sector. Private sector, basically, the for-profit private sector, their motto is to make profit. Without profit, they cannot survive also. So there is a profit component that will be there. But and so their profit interest will be satisfied when they focus on curative care, natural. So preventive care will not be of much benefit financially. But at the same time, they have a responsibility to support the government or support the people when it comes to preventive care. And this is happening also. So this polio eradication program, see, there were pulse polio rounds and all for last several years in India. The private sector was part of that. So this vaccination sites and all those things were there in the private sector also, across all sectors. And vaccination for children, that happens in the private sector also. And for national programs like TB control program, the private sector is heavily engaged, national level as well as in the private sector. And when it comes to tuberculosis program, it is demonstrating success because government made a lot of mechanisms so that private sector will be happy to join. For example, there are incentives. There are mechanisms for training the private sector. There are mechanisms for private sector to report directly, enter the data into the case-based, web-based reporting system. So these things should be there. See, for a private practitioner, for a private doctor, his time is also valuable. He is sitting in a curative center. So he will not be worried about the public health aspects. But government has to create mechanisms so that they will also get involved, or they will also they will also ensure the public health responsibilities as healthcare providers. That's why I gave the example of TB program. There are other programs also.
So, you said people seek out healthcare only when they fall sick. So, how do we inculcate health seeking behavior instead of treatment seeking behavior in populations?
See, this is a long process. So things are changing. See, a couple of decades ago, the health insurance was not a kind of common thing. But now, especially people who are employed, so they have these health insurance mechanisms. For people who are rich, they take health insurance. So these kinds of things are happening. So because of this kind of engagement, also people undergo examination, different tests to make sure that they are eligible for health insurance. So there are multiple mechanisms. Or for employment, people have to go through medical checkups and all. So these kind of mechanisms are additional things. But there is nothing, there is no kind of culture for us to have regular medical checkup. So that is not part of the behavior of the community. That's why, see, often cancers are detected very late in the process of the disease. That's why it becomes incurable or people die immediately after diagnosis, because there was delay in diagnosis. Why there is delay in diagnosis? Not always because people don't think about it, but that's also there. See, if you see some abnormality in your body, you have to think about the possibility of a disease. Then only you will seek care. Otherwise, unless you have pain or some major symptom, you will not think about a healthcare facility. This is why there has to be education of the community. Education is not very simple. No? People have to be made aware. See what happens even when people watch TV. See, in between entertainment programs, there will be advertisement, including health advertisement, gone. That's the time when people take a break. So, if I take an example of tuberculosis control program, I'm coming back to TB because India has the highest burden of TB globally. 25% of global TB incidence is in India. And it's on 2.7 million TB cases roughly every year. It's a major problem. And country has been struggling for many years. From 1962, we have a national program. And again, people reporting to hospitals, healthcare facilities, when they have TB symptoms, mostly cough. It was not at the desired level. So national government, since many years, they are using Amitabh Bachchan as an ambassador for tuberculosis. He comes on TV and says that even I had TB. So that will take away a lot of stigma and awareness also. A doctor coming on television and talking about TB, hardly anyone will listen to that program. But when Amitabh Bachchan, a popular celebrity, comes on TV and talks about this, these are the kind of, that's one level. The other level is you have to have community mobilization. Especially in Kerala, the three-tier local body government mechanisms are very active, especially at the lower level, Grama Panchayat and all. So you have to engage them. A lot of engagement is happening, but it's not very systematic. So you have to make a lot of efforts. Plus, civil society is very active in Kerala. NGOs are very active in Kerala. And literacy, education organizations, offices. So all these organizations should be equally involved in creating awareness. Health is multidisciplinary. Health cannot be taken care of by just hospitals or doctors or nurses. So health should be kind of responsibility of all kinds of organizations and all kinds of governments and all kinds of people. That's how when we will achieve. So just some giving messages over television by the department or some pamphlets here and there or boards stuck on walls will not change the behavior of the people. It may minimally do it, but you have to really have serious programs to influence the behavior of the people so that people will think about illnesses much early and seek care promptly.
So, like you said, that people people's behavior must change, right? So in Kerala, there's also a very high incidence of non-communicable diseases, and one of the so and one of the things that the family healthcare center does is that it monitors high risk individuals. So, do you think, sir, that maybe teaching people how to read food labels could be a better way to tackle, meaning to even prevent NCD incidents in Kerala? Are those the kind of strong preventive mechanisms that you were speaking about?
Yeah, there should be multiple mechanisms. See, in Kerala, we eat a lot of rice. Nowhere in the world people eat this much of rice. So there are reasons because it's very cheap. You can fill your stomach. So especially poorer sections, they eat a lot of rice to fill their stomach or suppress their hunger. So which has to be addressed by the government. See, government's also distributing rice everywhere. I'm not saying that rice should be eaten, but people who are doing kind of sitting and working in front of a computer, such people also eat a lot of rice as a habit. So these kind of things should be addressed. You see, what do you call it? Policemen, senior officials, army men, these kind of officials, politicians with huge belly. So this is very common. So you have to address. So somebody should be, some film actor should be brought in and told, to people that, see, I had a big belly, I reduced my belly, I eat less rice. This kind of, see, when we were young, no, especially when we used to go to villages, see, villages, especially grandparents, and they used to teach us how to eat more rice. So that, which is a big, what do you call, barrier to good health. So this kind of, so this should be addressed. See, because of political reasons or because of safe politics, people don't address such issues. Or when you don't have enough rice, what should we eat? Those kind of questions will come from the people. So there has to be serious effort from the government based on science, and these approaches should be scientifically done so that it reaches people. I remember an instance many years ago. One minister told in public in a meeting that people should reduce the quantity of rice and eat more chicken or egg or whatever. So there's a big issue. So people made fun of him, saying that he doesn't know anything. Where is chicken to eat? That's a reality. But so there should be adequate protein, adequate vegetables. Those kind of things are forgotten. Some people eat rice 3 times a day, 4 times a day. And you worry about diabetes. So you produce diabetes patients and you build hospitals and buy medicines to treat them. Why can't you address obesity at an early stage? When I talk about this, I was told that even doctors, 50% of doctors, and I don't know, but I just heard, 50% of doctors are overweight. So the culture has to change. See, it happens. There are doctors who smoke. How can you advise your patients to? So behavior change is not easy. And so there has to, I gave one example which is very easy to understand. There should be multiple exercise. Everyone buys cars. You have to move into, see, as countries become richer and richer, they move from car to bicycle and walking. People want to use bicycle. Even I want to do it, but I'm sure that if you use bicycle, it will be hit and run. It will be killed by road accidents. And even pedestrians, we don't think about footpaths. And in Kerala, pedestrians get killed. Those who go for walk, they want to remain healthy, they want to reduce weight, they want exercise, and people walk on the road and they are hit by cars and killed. So it's not just one area. It has to be a kind of multi-sectoral approach again. There should be good roads if people have to have good health.
So we're coming almost to a close. One final question. So you mentioned a few times that simply changing the name of the institution will not do any good, or that in itself will not be beneficial. And like you already mentioned, sir, this idea that primary healthcare must not only be curative, but it also must be rehabilitative and it must be preventive, palliative, promotive. That's been the assertion since the board committee report, and that has also been the assertion in all the national health policies. So, would it be right to assert that the Ayushman Bharat mission is simply old wine in new bottles? Is there anything within the Ayushman Bharat mission that you think shows promise in maybe achieving the goals for which the primary health centers were initially set up?
See, missions or new projects, all these are good, provided it happens. That's why, see, there should be political will to implement these things. It's not because we don't have rules in India that crimes happen. It's not because we don't have guidelines for driving in India. See, when you look at the number of accidents, road accidents, not because we don't have rules. So everything depends on how you implement it, how efficiently you implement it, and what are the monitoring mechanisms to check whether these are being implemented. So that's how we have to look at it. So there should be political commitment. It has to be done, that decision, which should be followed by fund. So we spend very little on health. So unless you have funds, you cannot work. You can write pages of projects or what you call missions in beautiful ink and print it. That doesn't satisfy the needs of the people. So that's why I said, so just declarations and meetings will not satisfy the. I'm not saying that things are not happening. The pace is very slow. I have lived in different kinds of countries, the least developed country at that time and in the developed world. So we have a lot to learn from other countries also. And so health is not a priority. That's what I used to feel. When I lived in Switzerland, the widening of a road happened close to my house just because of one accident. One pedestrian was killed by road accident. And that was the first time in their recent history. So next week onward, they started widening the road. See, in our country, dozens of people are killed in a single accident. And often remedial measures are not taken. People who live in developed world, when they come to India, many developing countries are the same, but especially a lot of people visit India. I used to hear a joke back when I used to live in the US. So the road signs in India are just suggestions. If you want to obey, you can do it. Otherwise, forget it. That's the kind of work. So that entire mentality or mindset has to change, for which there should be political commitment, enough resources, especially money, and efforts to educate people and make sure that these programs are implemented, and there should be monitoring mechanisms, and people who are responsible for monitoring or implementing, they should be accountable also.
Yes, I do agree with you. There does seem to be a gap in what the mission says must be done and what is actually happening on ground when it comes to health promotion and prevention activities. Most of the promotion and prevention activities, as far as I have found, has only been putting these mosquito repellents when it's like malaria season, or but there isn't any and even like for nutrition in pregnant women and in children, but maybe that's not sufficient in dealing with the health issues that the Kerala community today faces.
Kerala is the most fertile land for behavioral changes or implementing these things. But here also, see, for example, I have lived in Switzerland as well as USA. So I see people, very poor people, even homeless people, when they cough, they try to cover their face, or they cough into or sneeze into their uh, see, especially the coat or whatever. They try to, which doesn't happen in our country. It's see why see in many countries this is part of the school education. Right from school, they teach kids these kinds of habits, hygiene. So so washing hands. So we regularly wash hands after eating food. Before eating food, hand wash is more important. So these kind of these have to be taught in the schools. I remember when we were kids, we had a lesson which used to tell. So when you walk on the road, you have to walk on the right side, and when you drive a vehicle, it has to be on the left side. And the reasons were also told. I studied in primary class. I still remember. What is why? Why? Because when you walk on the right side, vehicles are always on their left side. So you can see the vehicle coming from your front. And the vehicle from your behind is on the other side. So that is not going to come and hit you. So simple thing which I learned in primary class, I still remember. So this kind of lessons, this kind of what do you call it, descriptions or what examples should be given at primary school level itself, so that it will go directly into the brains of future citizens.
Yeah, so that's something I've actually observed, that healthcare in, I'll speak specifically for Kerala, because it seems like healthcare is like your personal health is still a third person's responsibility. It's the responsibility either of a doctor or your ASHA worker or your primary healthcare center. It's rarely individuals are rarely made responsible for their own health. So perhaps that kind of a shift might also help in developing, um, health, inculcating health seeking behavior in people, in populations in Kerala.
We can teach people, see, cough hygiene, using your own kerchief or tissue paper. These kinds of things should be taught. This can happen. See, we did a study during COVID, and more than 90% of the people studied, they were using masks. That's possible. So 95% use of masks. It can happen in Kerala. So like that, if people are taught and people are trained, things will slowly change. So for that also you have to have a decision. So what happens is, especially in Kerala, when it comes to health, many things happen randomly. Even this recent episode of Nipah outbreak, we can see that things were not done, even though we had 3 years experience of Nipah. We were not prepared. Even the government system was not prepared. People were not told. People were not, health staff were not trained. So this kind of lack of preparedness and lack of seriousness is there even in health. So, and the other thing is, Kerala has the kind of history of number one, promoting or overinflating the example of number one. We are not number one everything. Overall, Kerala health status is good because we live longer. Our infant mortality rate is low, our maternal mortality rate is low. Those kinds of things are there. But we are not a good example for when it comes to suicide. We are not a good example when it comes to road accidents. We are not number one when it comes to diabetes. So we try to live in the past, saying that Kerala is number one. So which will give a wrong kind of impression to the people. So we are number one, so we shouldn't be doing anything. See, cough etiquette, covering the face when you cough and sneeze. Even now, people think that it is necessary only during COVID. So if COVID doesn't come back, you don't have to use a kerchief or tissue paper. That should not be the case. Spitting, Kerala people, we are very clean, but we spit everywhere because we want to throw out the dirty thing in your mouth to anywhere. So those kind of things should be changed by continuous education.
Yes, I also read that even when it comes to NCDs, non-communicable diseases, there was a NCD study that was done in 2016-17, wherein it was shown that Kerala is one of those countries wherein the level of morbidity is very, very high. So while we do, like you said, so while we do well in life expectancy and infant mortality, there still does exist problems such as these that do need to be remedied. So,
Quite
sir, thank you.
natural. That's quite natural. See, when you control your infectious diseases for those kind of reasons for death, the people will live longer.
Mhm.
So when you live longer, so there has to be some reason for dying. So if you are dying at the age of 30, which used to be the case before independence, people may not develop hypertension, or people may not develop diabetes, so or cancer. So of course, very rarely young people also get these diseases, but generally these are diseases of older age groups. So when people live for longer years, you will have all these diseases. So the mechanism, that's what Kerala has to do. We should be prepared to face the real problems, which is going to be a big issue in Kerala, like old age people, their problems, their health problems, their social problems, which we need to address. Already the life expectancy of Kerala is very close to US, and women life expectancy is equal when you compare it with US life expectancy. So people, but developed world, when people live longer, they have social mechanisms. They have old age home. There are mechanisms to take care of old age people, and there is money that comes back to your care from the government. Those kind of mechanisms are there. Here we don't have such efficient mechanisms. So old age becomes the problems in old age becomes the responsibility of the person as well as family. And people live longer, so that adds burden to the next generation. And three or four generations live in the same home. And life, no, see, there will be morbidity, especially in the older age groups. The money saved for education or something else for the younger generation will have to be spent for the treatment and care of the older generation, which will completely upset the financial status of equilibrium of the family. These things are there. So this also has to be seriously thought about, and the future plans and future policy should be based on these kind of bigger issues waiting for us.
Thank you so much, sir. That has been a very fruitful discussion, I think. So, to just summarize what we've discussed today, uh, we've agreed that to ensure that there is equitable, affordable care, it cannot be achieved without intervention. And that is why primary health centers are required specifically for to ensure that even rural people, people living in rural areas, have access to healthcare. We've established that there is a preference in Kerala for the primary healthcare in the primary health sector. Almost more than 70% of people rely on the primary health sector for healthcare. But this is not necessarily a bad thing, because the private health sector must be made a partner in healthcare in ensuring that quality care is provided um, across populations. The government must also support these the private sector, and they must also create mechanisms for uh, private healthcare providers to be interested in um, disease prevention. Health is a multidisciplinary sector, and efforts just from one sector is not sufficient. We've also established that to inculcate a health seeking behavior in populations, there has to be cultural change. There must be changes in, say, our food habits. There must be changes in our lifestyle with changing incidences of diseases. We've also established that political will, funds, and resources are vital when it comes to setting up and ensuring that there is um, a proper pace when it comes to implementation of any mission or scheme that the government might come up with. Finally, we've established that maybe policies should now look at the new and developing problems that Kerala might face in the future, considering that there are demographic changes caused due to improvements in healthcare and infectious disease control. One thing that we've mentioned is that there is going to be a problem of providing care, that Kerala is not prepared enough to meet the social and medical needs of the aging population. Thank you so much, sir, for your time and such an engaging discussion. Thank you also for accepting our invitation and making time to be here today. I'd also like to thank our organizing team at CPPR for the smooth function of this webinar. With this, I'd like to formally close today's session. Thank you once again and have a great
Thank
week
you.
ahead.